Good afternoon, everyone. Welcome to our next session in our Boosters and Beyond series, addressing key challenges. After the holidays, we thought it'd be a really good idea to get together and talk about respiratory viruses in the winter. We've just had everyone come together for the holidays, families, seeing our residents, a lot of the visitors, even us being with our own families, probably unmasked. So we're going to be talking about the respiratory viruses today and its implications. I have Mary Ellen Casey, who's going to be leading the discussion, but we do have a few housekeeping items to get through. Apologies. If you're not familiar with who we are the IPRO QIN-QIO. The federally funded Medicare QIO contract for the 12 regions shown here. IPRO specifically helps cover New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the IPRO QIN-QIO banner. So if anyone asks you if you know who IPRO is or if you're working with IPRO, you say yes. So just to give you folks a heads up, this is a new series for our Booster and Beyond. Last series we talked about readmissions. With this new series, we'll be discussing boosters, NHSN reporting, staffing and support, and then specifically starting next week, we're going to get into the CDC's core infection prevention and control strategies. So we'll be going over that. So if you have any burning questions about any particular topics, please submit them into chat so that we can integrate it within our curriculum. And with that, I'll pass it over to Mary Ellen.
Thanks, Josh. Good afternoon, everybody. I just want to start with what we typically start with for these sessions, an influenza and COVID update. And this is data current as of the 6th of January that for influenza, the activity does remain high across the country, but the good news is we're continuing to see a decline in most areas. Hopefully that will continue post-holiday get-togethers. The strains are the same, H3N2 followed by H1N1, and the flu vaccine continues to be a good match, which is very good. And the antivirals are still effective against these current strains, so that's also good. Hospitalizations are really similar to what we saw last week. However, there have been an increase, as you can see here on the slide. Next slide, please. As far as COVID, hospitalizations have stayed pretty stable for the last week. And these are through the 30th of December, so it'll be interesting to see where we're at in another week or two. But there was a slight decrease. It's not really statistically significant. The 7-day average still remains at over 6,000. As far as the booster, we're still ticking up slow in the right direction. As of the 4th, we had over 48 million people with the updated booster. It's only 38% of adults 65 and older that have actually received the updated bivalent booster, but I would venture to guess, sort of with the data lag, that number is probably a little better. The latest variants, actually, I forgot to update the date, but this is actually from the 4th of January, the latest variants report, and you can look at that on their variant summary page. But the current strains circulating are continue with the BQ1.1. But we've heard an awful lot about XBBB 1.5, which is the new kid on the block, but it's kind of wreaking havoc, particularly in the Northeast. It doesn't appear to cause serious illness, but it is the most contagious variant so far, and it has managed to elude whatever immunity you may have. So that's a tad discouraging. BQ.1 is still circulating, and remember that these are all variants of the Omicron strains, weakened strains, if you will, changes. So the vaccine will provide some protection against them. Next slide. I updated this slide, and this is new for the COVID-19 tracker on the CDC website, where they're actually posting each week the percentage of up-to-date COVID-19 vaccines for nursing home residents week to week, and we're going in the right direction. So it's good to see that, we're at 47% up to date with the long-term care residents as of the 1st of January. And as I mentioned, I think, we're probably in a data lag. So I would expect these numbers are probably going to improve. And it's really the efforts of all of you. This is a very tedious and long campaign, but well worth it. As you see, the variants are fighting back. Next slide. And this was good timing. With this article just came out, JAMA, they did a research study looking at the extra booster vaccine and comparison of residents that got 3 vaccines versus 4 vaccines. And with that extra booster, a study came out that really validated one that was done in Israel over the summer. And they compared nursing home residents that had had the primary series and a booster versus having a primary series and 2 boosters, and found that although there wasn't great results from actually eliminating the virus altogether, what we did see was decreased hospitalizations, decreased serious illness to the effect of 74%. In some cases. So I think it's good information to help support your conversation when people are just so booster fatigued. It's like, why do I have to do this? I think, with each reiteration of these vaccines, we get better at it. And certainly, while it doesn't prevent the infection, it certainly prevents all the things that we don't want to see as a result of it. So, and we included these links in the resources too, if you want to read more on this study. It's really interesting. Next slide. So learning objectives for today, if you're a virus geek like me, there's lots of reading material I put in the resource list, but I've always been fascinated about how viruses spread in the winter, why they do. So this is really a session on talking about how they spread, how the cold weather impacts respiratory viruses. Look at a really interesting research study on the biological mechanisms that are associated with increased susceptibility to respiratory viruses during the winter, and then review some basic infection prevention measures that will be no surprise to anybody that we'll just review. Next slide. So virus veracity, the truth about viruses, they've been around a lot, and there's so many of them. And I think with COVID-19, we sort of put them on the back burner. And with all the infection control measures surrounding COVID-19, we always talk about collateral damage, but COVID-19 was actually collateral benefit because we were so good at our infection prevention measures that we really kind of eliminated these other very common viruses that have been circulating. And now you can see we have a lot of circulating viruses ordinarily in the cold weather. So you're adding to that a flu season that hit early, it hit hard. We're co-circulating with RSV and COVID-19. My goodness, it's been a really challenging season thus far. Next slide. So the background on upper respiratory tract infections, we know that they pose a significant public health burden. It's not even the fact that you're getting sick from these viruses. It's a public health burden in terms of decreased productivity, absenteeism, healthcare system overload. We see this night after night in the news about there's not enough beds for all the sick folks. We know these viruses are associated with multiple clinical scenarios like ear infections, sinus infections, bronchitis, pneumonia. And to add insult to injury, you're dealing with the illness itself. It's also exacerbating some comorbidities where you end up in the hospital where you don't want to be at this time of the year, if at all. The viruses are dynamic with significant mutation rates. They've been described as highly evolutionarily dynamic. I wish someone would describe me as that, but viruses are very interesting because they have significant mutation rates. They just do it so quickly. They're able to evade pre-existing immunity, as we're seeing with the XBB variant. So they will always pose a significant risk of emerging and re-emerging unpredictable and life-threatening epidemics and pandemics, and we're sort of living history because we're seeing that now. Next slide. So why do respiratory infections happen more often in the winter? Seasonal variation with increased URI prevalence and morbidity and mortality during the winter period has been well recognized. And it certainly is exacerbated by socioeconomic factors and behavioral factors, and age and sex and comorbidities sort of rolled into one, which, if that were enough, environmental factors will contribute to that epidemiologic phenomenon, but scientists aren't really sure. They don't have a clear understanding of why that happens. So there's a lot of theories about winter conditions. It causes people to stay inside, increasing the spread of infection. It can weaken people's internal protections, increasing your risk. But really, winter weather creates the ideal conditions for the viruses, increasing the risk of infection. So winter weather can increase virus longevity. It improves the ability to circulate. All of these viruses that, the common cold and the flu and coronavirus that existed before SARS-CoV-2 are more active in the wintertime. These cold conditions allow viruses to linger in the air for longer periods of time. You wouldn't think so because, human nature, I want to be someplace warm. I don't want to be out in the cold, but they love it. And they separate into fragments that make them even smaller so that they can stay active and they float longer and farther. So there's a real scientific mechanism to it that you don't think about often. Next slide. I thought this was a great visual of the talent of droplets. We talk about this a lot, and there's been so much conversation about what's the point at where you wear an N95 mask with COVID-19, and the science was new. They were back and forth. Wear a surgical mask. Oh, wear an N95 mask. Well, we're not sure. Maybe it's a high-risk procedure. But there's a lot of reason for that. And one of the reasons is the mechanisms of droplets' reaction to weather. So if it's wet and humid, droplets are heavy, they're larger, and they fall due to gravity. So, a face shield in a case like that is probably more than enough protection in those kinds of circumstances. But as the weather transitions and it becomes drier, then the droplets become smaller. And so, it's hard to say where's the droplet at. You can't see it when you're trying to determine what's good protection. But you can bet that as the weather gets cooler, a well-fitting mask is going to work better because it's going to protect against the smaller droplets. And then as the droplets evaporate in drier air and they disperse easier with air movement, they become known as droplet nuclei, and we know them as aerosols. And a lot of talk about aerosol generating procedures that sort of force the droplets into this small, tiny little nugget that's floating around and has a better ability to invade you. So N95 respirators work better because it's a much tighter seal and the small viruses can't get in. So I thought this was sort of a great way to kind of look at it when we often talk about, well, assess your risk and kind of think about your environment and what's going on with the resident as far as impacting your risk. Next slide. Oops, here we go. So cold temperatures create ideal conditions, and cold and flu viruses has actually been flu has really been studied for quite a long time. It's a myth that cold temperatures cause the flu. Really, it turns out that the lack of humidity in the cold air is the driver, particularly of influenza, because they just love it. They don't do well in humid, moist conditions. They tend to kind of drop off and not spread as easily. But if it's a dry, cold environment, they spread like wildfire. They tend to strike in chillier months. They thrive in this kind of weather. And at the opposite end is the human response. We don't do as great with the cold weather. Our nasal passages are drier. It's harder to clear mucus in cold weather. And then a lot of holidays are during the cold weather. So there's social gatherings, you're inside heated residences where that will dry the air even more. And of course, traveling, it'll be interesting to see how the numbers that we look at every week change because of the traveling from the holiday. Next slide, please. And the flu virus, well, that's been studied for a very long time, especially the outer coating of the flu virus. And you probably hear a lot about that because that covering mutates and changes, and therefore changes the composition of the flu vaccine. But the outer membrane of the influenza virus is made up of lipids, and research has really shown that temperatures slightly above freezing and temperatures below freezing really help this lipid solidify into this gel. At the same time, in warmer temperatures, if it's above 70 degrees, that gel will melt to a liquid phase, which is great if it's out in the environment, because it won't be able to travel and invade hosts. But you take the two characteristics together, and that doesn't help us, because the virus's rubbery outer coat allows it to withstand the cooler temperature, so it can travel from person to person. And then once it gets into the respiratory tract, and then obviously temperature above 70, it's the body's warmth that causes it to lose that covering, and then it can go in and infect all the cells of the host. So it's very talented. This particular study used M&Ms as an analogy, and said, think of an M&M, that it has the hard coating. Once you put it in your mouth and it warms up, you lose that covering, and voila, you taste the chocolate. So I don't think I'll ever eat another M&M again without thinking of the flu, but there you go. Next slide. So a more recent study was in 2022 in the Journal of Allergy and Clinical Immunology. And again, if you like reading about viruses, this is a really fascinating study. It's a little bit long to read, but I included it in the resources. And they took an approach that there's got to be a biological mechanism to all this. You can't just say, don't go out in the cold. Did your mother ever tell you that if you go out with wet hair, you're going to catch a cold or pneumonia? That's a myth. But the nasal cavity is actually one of the initial contact points between the external environment and the human body. And it is highly sensitive to changes in ambient temperature. I thought it was fascinating because I don't really think about my nose too much, but nasal mucosal barriers represent the first front line of defense against exposure. So we've got these, and they have a title. So we have these nasal epithelium-derived extracellular vesicles, say that 3 times fast at a party, these EVs that are sort of little soldiers in your nose, and they play a few roles in antiviral immunity, protecting the host from viral infections. First of all, they sort of stand guard to prevent that virus from actually entering your nasal cavity. And then they secrete what is called TLR3 and mRNA, remember that term from vaccines, but they actually secrete that, and it allows them to bind to the virus and keep it from infecting the respiratory system. If you go to the next slide, Josh, I'll just show sort of a very fancy picture of what's going on. So on the left-hand side is just really a snapshot of your EVs inside your nasal cavity, and in the gray and purpley looking cross-section of it is all these compositions of antiviral secretions that are floating around and keeping guard. On the right side, it shows the ambient temperature versus the cold exposure. So you can see the brown little EVs sort of lined up, ready to take action against the bigger droplets because it's warmer or ambient in temperature. And then in the cold exposure, while the virus loves the cold, the EVs do not. So they are impaired by the cold weather, which makes it challenging because it does two things. It decreases their number that are actually keeping watch at the gate, and it increases its ability to secrete these antiviral warriors that attach to these viruses. So it's a really fascinating study, and really sheds some light on it's not just, oh, the cold weather is causing all this, but a real biological immune response going on in your nose, which, makes me think about some of the interventions I even do in the winter time, like dry nose, nasal drops, or, running humidifiers in the house. There's actually a science behind that as to why it works. So you're boosting your nose immunity, if you will. Next slide. So moving on to trying to differentiate between all these viruses, and I'm sure every participant on this call has struggled with this in the infection prevention world, especially in light of COVID. Like, well, what is it? So what's in a cold versus what's, before it was just really comparing cold or flu in the winter season. Now we have a lot more to think about. But this is an infographic on the CDC website, and it's still there, which is good because oftentimes we're asked to weigh in on this. And, when you look at cold symptoms are usually milder, and people with colds are more likely to have runny or stuffy nose. So colds are sort of, you kind of see it coming, sort of, or you kind of feel like I'm starting to get a cold, where the flu is really abrupt for the most part, that you wake up or it just all of a sudden somebody flipped the switch. And that's a good differentiator. And colds generally don't result in some of the serious health problems that we see with the flu. Cold is probably more common because there's so many different viruses that cause it. And so I think we've been well protected for the last couple of years. So it's not that our immune system is any worse the wear. It's just that and we haven't been exposed. So it's sort of an onslaught now of all these viruses that have had a vacation, if you will. Next slide. The harder thing, I think, is comparing the flu and COVID. And this is just a chart I put together for this presentation based on, the description on the CDC website, which is it's a great page. It's a lot to read through. And so when you look at similarities between flu and COVID, there's a lot that I'm sure is not a surprise to people in terms of symptoms. Both can be asymptomatic, we know that. And the similarities with symptoms, pretty much across the board, fever, sore throat, muscle aches, body aches. Even when you think about loss of taste or smell, you can have a change in taste and smell with the flu. It's a little bit more obvious with COVID when folks who have it describe that symptom of I had no taste, no smell. So you can kind of gauge from that if it's maybe flu, more likely COVID. We know as far as transmission that they both spread from person to person with droplets, large and small particles that are expelled, from the person who's infected to whoever's in the line of fire. The challenge with COVID, and we didn't really talk about this with the weather, is that COVID does not show any preference for seasons. You can get COVID pretty much any time of the year. Don't know if that'll change and it becomes more like what we're seeing now in the winter, but that's definitely something to keep in mind, that season is never over, at least for now. Symptom onset, the similarities are that 1 or more days can pass when a person becomes infected to when they actually start experiencing symptoms. But they diverge a little bit in terms of when that actually happens. The risk is the same as far as the population. So the higher risk is in older adults, those with comorbidities, and pregnant women, and the complications are pretty much the same, at least the most common ones, with pneumonia or respiratory failure, sepsis, cardiac injury, and the worsening of those chronic medical conditions, which again is so concerning. The difference comes with some specifics as far as onset of symptoms. The flu, you're actually usually see symptoms from 1 to 4 days after infection. With COVID, it's 2 to 5 days and can be up to 14 days after infection. So COVID sometimes surprises you, and I'm sure folks can think of times. I know I've had when I have worked in infection prevention and employee health, and when we were isolating or keeping folks, healthcare workers home, you thought you were out of the woods. And by gosh, day 14, you thought they're going to be okay. And day 14, they got COVID. So COVID's a little bit, takes a little bit more time sometimes. As far as how long you're contagious, there is a difference between the flu and COVID. Flu, you are potentially contagious for about a day before you show symptoms. However, it is strongly believed that flu is spread mainly by people who are symptomatic. So sometimes you feel like you dodge a bullet, but seems to be a smaller window with flu. However, older adults, if they're immunocompromised, that idea of they can shed a little bit longer is possible both with flu and COVID. COVID on average begins spreading the virus about 2 to 3 days before symptoms begin. But infectiousness actually peaks 1 day before their symptoms begin. So, which is interesting, and it's not everybody, but we worried so much about that, being around people with COVID, that it's sort of the Pandora's box, that you probably are exposed oftentimes before that person knows that they have it. So transmission, we know COVID is much more contagious than flu. Remember the super spreader events, back in the day? That happens more often with COVID than flu. And while there's a higher risk similarity with populations, there's a much higher risk for severe illness with COVID, particularly when you see a lot more healthy people in the population getting severely sick. So that's sort of a difference with COVID, and the fact that we're seeing, post-COVID conditions, which I'm sure, folks are aware of, with long-term COVID and all the symptoms that go along with that. As far as complications, secondary bacterial complications, and we talk a lot about that with, that progression to a bacterial flu from a virus. It actually is more common with the flu than COVID. And we also know COVID is independent from the flu in the sense that it causes blood clots, multi-system inflammatory syndrome we've heard a lot about, and where where flu lasts maybe for up to 2 weeks once you're sick with it, COVID can last weeks or months with, thinking that you're better, and then, a month or so later, you start having symptoms of long COVID. So that's just some of the many, many similarities and differences that you can read about on their webpage. If you have, I think with all this education and all the research going on, it's a little bit easier going to the CDC website to kind of see where we're at with these things, where before, we're really kind of guessing. So next slide, please. And I just put this together based on the CDC website, because I think sometimes a visual is really helpful when you're getting these rapid fire phone calls, or you're having conversations with residents or their families, like, well, what is it? Is it this? Is it this? And this can sort of guide where you see some of these symptoms, whether it's common or rare, or you probably wouldn't see them. It kind of gives you an idea and some guidance about where to go, what your clinical decision may be in cases of all three of them. Next slide. I wanted to mention seasonal allergies. I don't know if folks had to deal with this, but I remember this was a huge problem in siphoning through all the symptoms. Seasonal allergies, especially that first winter of COVID. If you're in an area where the end of the winter and the beginning of spring is active allergy season, it's a nightmare. You're testing everybody. It doesn't matter. Here in Rhode Island, I feel like seasonal allergies, there is no season. It's constant. But this is an infographic on CDC. It's still up there, just sort of pointing out some commonalities, when you're trying to assess, is this COVID? Is it seasonal allergies? Is it a cold? Still kind of challenging to sift through all this, but this kind of gives you a place to start when you're looking at some of the symptoms. Next slide. I would be remiss if I didn't mention RSV because of the way it jump-started the season. But in adults, it's pretty serious. Or we talk about the pediatric population so much, but between 60,000 to 120,000 hospitalizations occur a year because of RSV in adults, with 6 to 10,000 deaths, which I was amazed. I don't think of RSV, I think of the pediatric population, and sometimes I'm sure for folks on the call, this is as much of a concern as any other virus. But the highest risks include the folks that we know well and deal with on a daily basis. And again, it worsens certain conditions. So, and this is a tough one because there's no vaccine for this, although there is one in testing and whatnot, at least for the kiddos. But I don't see the rush on this like we did with the COVID vaccine. Next slide. CDC this is the only reference or patient education sheet I've ever seen for older adults on RSV, and it's a really nice one. You can print it out in color, you can post it. It's great for non-clinical and clinical staff really talking about this. And what I like about it is it adds, a lot of the basic infection prevention measures that we would use with any virus, but it sort of, reiterates it to folks. So I think Josh put the link in the chat, which is great. So it's just a really great tool for folks to use, and they don't advertise it often enough, I think, with the focus on pediatrics, and rightfully so, but this is a really great tool. Next slide. So which leads me to basic precautions, which, in the world of infection prevention, we're just very redundant messengers, but that's okay. Good hand hygiene, you can read any recommendation, any research study you want, and hand hygiene is at the top of the list as far as mitigating getting sick. And I would like to say, I probably should have moved it, but avoid touching your eyes, nose, and mouth. If you could marry those two practices together, like peanut butter and jelly, that to me is like really good. And I am not good at not touching my eyes, nose, and mouth. I'm guilty as charged. But it works because, you think of it, if you're shaking hands in a situation where you really don't want to shake somebody's hand, if you just kind of think about it and say, well, let me just keep my hands away from my face until I can get somewhere to wash my hands, you're going to mitigate your risk. So that is, the sort of the bread and butter of infection control, but and respiratory etiquette and social distancing, and remember, it's never too late to get vaccinated. The other way to minimize your risk is get tested, because then you can decipher what it actually is that the person has. We have PPE fatigue, totally get it, but if you don't wear it properly, it just does not work. And cleaning and disinfecting, I can't say enough about that, because viruses, while they love human lungs and the nasal passages, they absolutely hate the environment. They don't do well on it. So cleaning and disinfecting is gonna really do a lot. It goes a long way. And stay home when you're sick. We were pretty good at that with COVID. I see that sort of slipping away as people experience other illnesses, but it's really important. Next slide. And I invite my colleagues to jump in. I know we've gone over a little bit as far as viral respiratory panels. We've talked about this before. The definitive testing is important because, as you can see, there's a lot of viruses out there that aren't necessarily COVID or flu. Next slide, please. But how are you testing? Are you using rapid testing exclusively? It's a really important tool. I don't think I would have survived the pandemic without it. But do you have a process for sending out? And does your lab provide a full respiratory panel? When I was working at the hospital and COVID started, we assumed we had a full respiratory panel. We did not. We sent them out. And so the hospital changed that practice pretty quickly. I was just floored. So I'm just curious. It can be a burden, especially logistics and financial and all that, but I just think it must be hard to navigate the waters and long-term care with all these things sort of circulating around. As Josh mentioned, holidays, people, probably more visitors coming in than you typically see because of that. So any thoughts from anyone? in the meantime, while people are chatting, I just want to put a plug. CMS just put out this new education series called CMS QI Voices, and they're really great short education sessions to help support vaccine efforts, which is great. They recognize that you guys are, going above and beyond, really trying to get those vaccine rates up and doing a great job. And this is just, a little extra added short education to help promote those efforts. So check that out. I think Josh just popped it in the chat. And I think that is it. There's resources here, and I know we put this presentation through its review for compliance, and you guys will get a copy of it. So
yeah, thanks so much, Mary Ellen. I know we're a little bit over time, and I did put the links from all the resources that Mary Ellen mentioned into chat. But does anyone have any quick questions for her before we end the call for today? Feel free to put them in chat or come off mute.
hopefully everybody's staying healthy.
So Sheila wanted to know if anyone is doing rapid flu testing for staff. So any other facilities on able to answer Sheila's question? She would like to hear from our colleagues in the other facilities. So Hope shares that they're just doing them on residents, and Christina had shared that we have done a few. Thanks so much for chiming in. Laura also shared that yes, symptomatic staff who are COVID negative, they do the rapid flu testing. And Christina shared mostly when they have been in a facility for a few hours. Sorry, chat was moving too fast.
Good comments.
Yeah, mostly have when they've been in the facility for a few hours without reporting illness. And then Sheila mentioned, I was just looking into it for pricing, etc. Yeah, so I don't see any other questions in chat. Thank you so much, everyone, for chiming in to share your own experiences with Sheila. These sessions are helpful not only from us, but for you folks to all learn from each other as well. The recording of today's session will be played tomorrow again at 3:30. So if you know anyone who would benefit from today's session, make sure that they come for tomorrow's session for the recording. And then this Thursday at 11 a.m. we have our live IP3 session, infection prevention content for infection preventionists by infection preventionists. So we hope to see you there as well. That will be it for today's session. Thank you so much, everyone. Hope you have a great day.